There is significant interest in developing bispecific antibodies in acute myeloid leukemia based on the success of blinatumomab in acute lymphoblastic leukemia. AMG-330 is a bispecific construct recognizing CD3 on T cells and CD33 on AML blasts. Now, CD33 is a validated therapeutic target for antibody-based therapy in AML, obviously with gemtuzumab ozogamicin being an antibody directed at CD33. So with this, the bispecific brings the T cells in close proximity of the CD33 expressing blasts and results in T cell activation and T cell mediated lysis of the leukemic blasts. This was a first-in-human dose escalation phase 1 study in patients with relapsed and refractory AML. The study is ongoing, but we have reached very high daily dose levels. The main concern for bispecific antibodies is cytokine release syndrome. And in this study, we have managed to now mitigate this by using steroid prophylaxis as well as by a step-up dosing strategy. So the first 5 cohorts were single patient cohorts, and we established 10 micrograms daily as a good first step for initiation of AMG-330. And then subsequent cohorts were 3+3 design, and in those cohorts we have used a 2 or 3 step increased dosing strategy. The dose for the second step was 60 or 240 micrograms daily, and the dose step up for the third step was 600 micrograms daily. And those steps occur about 1 to 5 days from the previous dose step up. And with this strategy and with the use of prophylactic dexamethasone as well as judicious use of tocilizumab, we have been able to administer doses as high as 840 micrograms per day continuously for protracted periods of time, and therefore allowing higher dosing of AMG-330 and allowing a better steady state level concentration. Other concern with bispecifics in AML has been that CD33 is also expressed in early normal myeloid progenitors, so there's been a concern about myelosuppression. However, we've had responses, including CRs and CRIs, with recovery of neutrophil count, which suggests that this may not be a major issue. To date, we have treated 60 patients with a median age of 58. Most patients were multiply refractory, with a significant proportion having had 4 or more prior lines of therapy, and about a half having had prior allogeneic stem cell transplant. Essentially, the response rate has occurred mainly in the latter cohorts with a higher target dose. So, for example, in the last 3 cohorts, the response rate has been 21%. Overall, there's been 3 CRs and 4 CRIs with 1 MLFS. And some of these responses have been durable. Patients have also had responses after prior transplant. And 1 patient was able to bridge to an allogeneic stem cell transplant and continues to be in remission. In terms of toxicity, the main toxicity has been CRS, as mentioned previously, with about 15% grade 3 or higher CRS. As I mentioned, myelosuppression has not been an obvious problem because, again, some of the responders have recovered neutrophil counts. So overall, the study just shows that this drug is feasible and effective in relapsed and refractory AML, and the study is continuing to accrue patients in the participating centers. We are now currently at a higher dose as a target dose.